Hello, thank you. Welcome to the Sleep Apnea Patient Seminar. I'm Dr. Ketan Deoras. I'm joined by Dr. Ryan Gerritsen. Just going to briefly introduce ourselves here. So I did my training in psychiatry at the University of Arizona and completed a sleep fellowship at the Cleveland Clinic. Worked there for some time. And I've been here at Summa for the past 3.5 years, currently as the division chief of sleep medicine here. I'm going to toss it over to Dr. Gerritsen.
Hi, I'm Dr. Ryan Gerritsen. I'm one of the ear, nose, and throat surgeons here at Summa. I've been here 2 years now, actually to the day. I did my medical school at Ohio State, and I completed residency training at Thomas Jefferson University in Philadelphia, Pennsylvania. While they're known for they're a top 10 program in ear, nose, and throat surgery, and they provided me with an experience to see sleep medicine and sleep surgery in depth, and was one of the most prominent centers to do the Inspire device. So through my training there and seeing the collaboration between sleep medicine and the surgery side of things, and being from Ohio, it was my desire to come back to Ohio and help develop a sleep medicine program wherever I worked. And so Dr. Deoras and myself have started, along with the other ear, nose, and throat surgeons and the other sleep medicine doctors, to try to build this program up. And we're going to talk about that more in depth today. So just quickly, kind of the topics that we're going to hit today. So we'll discuss exactly what sleep apnea is and some of the causes of it. Dr. Deoras will talk about some of the signs and symptoms to look for sleep apnea, how it's specifically diagnosed, and I'll cover some of the long-term effects that can come from untreated sleep apnea, and we'll both talk about some of the tried and true treatment options, as well as some of the newer things that we can offer to treat sleep apnea. So what is it? So a number of patients will come to me and say, well, I snore, and so I'm pretty sure I have sleep apnea. But truly what the real definition of sleep apnea is there's some obstruction in your airway at night. So while you're asleep, there's either a complete collapse or a partial collapse lasting for more than 10 seconds that obstructs airflow and results in oxygen depletion. And there's different types. The one that we're predominantly interested in is the obstructive form. So there's some anatomical cause in your upper airway that collapses and blocks the airflow. One of the more rarer causes is central sleep apnea, where there's a failure of a signal from the brain to the muscles that control your breathing. It's far more rare than the obstructive component, but it's something that Dr. Deoras will touch on the sleep studies. And there's also mix. So sometimes when we treat your obstructive, there's a central component that kind of comes out, and so you'll have a mixed component of both of those types. Some of the things that can cause sleep apnea or have been linked to it, one that's most kind of comes to the forefront is obesity. So as far as the severity of your sleep apnea, there's been a direct link as the BMI increases that your AHI, or the measure of how severe your sleep apnea is, also increases proportionally to that. Some of the easier direct measures are your waist to hip or your neck circumference. As that increases, that's sort of a clinical indicator that potentially there's sign that sleep apnea is more likely. Some patients, anatomy-wise, so some patients have certain craniofacial structures, or they'll have their jaw that's a little bit more retruded or retrognathic, that just predisposes you to obstructive events. Aging's a big cause. So as we age, sleep apnea becomes more prevalent, and it's directly linked to the changes in our tissue and our anatomy. We lose that elasticity, and things within our throat and our upper airway it collapses much easier. And gender plays a big role. So in numerous studies, men are 2 to 3 times much more likely to have obstructive sleep apnea or sleep apnea compared to females.
And so when we're seeing patients in the clinic and they're presenting, we're trying to assess for the signs and symptoms of sleep apnea. I'm usually breaking it down to what's happening at night and what's happening during the day. So in terms of the nighttime symptoms, a common one that people are coming in with is snoring. And then, of course, if they're telling us they're actually waking up, gasping, choking, that's something we have to be aware of that kind of raises our alerts for this. And witnessed apnea. So oftentimes a person's coming in because their partner is actually seeing them stopping breathing in sleep, and that's kind of the impetus for the visit. Awakenings throughout the night. So sometimes as we're struggling to breathe, that can be a sign for the brain to make us get up just to kind of improve the oxygenation at night. It can be a very restless sleep. We'll see more night sweats as people are struggling to breathe as well. And then we'll also see a lot more nocturia, which is getting up to urinate throughout the night. There can be very frequent urination. Dry mouth, patients as they're sometimes struggling to breathe will open their mouth trying to get in more air. We also see increased reflux, and then of course bed partner disruption. This is all kind of going on throughout the night. And then in the daytime, patients will complain of feeling more tired and sleepy, which makes sense if you're stopping breathing throughout the night. Your organs, your tissues, your cells aren't getting well oxygenated. It's not going to be as refreshing of a sleep. We can see more headaches, especially cognitively as well. Like when the brain's not getting good oxygen, we can see headaches as well as memory and concentration issues. And then even mood symptoms that can come along with this too. So there have been numerous studies showing not only like irritability, but depression can be a side effect of untreated sleep apnea too. And then also decreased libido. And definitely we've had many cases of drowsy driving, which is a scary thing, but people either falling asleep at a red light, a stop sign, or even worse, while they're driving and getting into an accident. So these are all kind of the things that we'll see as we're, assessing patients for sleep apnea. And before I go into the diagnosis further, I just wanted to let you know where Dr. Gerritsen and I will be kind of presenting for 40 minutes here. We're compiling all your questions as we go through, and then we'll be answering those when we're done. But in terms of the diagnosis, so on top of getting the patient's symptoms when they come into the office, we'll use scales. So for example, one is called the stop bang. And so stop is a mnemonic. So it stands for, the S is for snoring, T is for feeling tired, fatigued, or sleepy. The O is for observed apnea. So has someone seen you stop breathing in sleep? And then the P is for high blood pressure. So if patients present with two or more of these risk factors, we already know that they're at a risk for having sleep apnea. And most of the time, though, we'll supplement this with the additional four of the what's known as the BANG. So the BANG stands for B is for BMI over 35. So the BMI is our body mass index, kind of looking at our proportionality of weight to height. Above 30 is considered obese. And so if they're above 35, we know that's going to be a higher risk for sleep apnea. Age above 50, as Dr. Gerritsen explained, we know that age is a risk factor. And then the neck circumference, once we get into the 16 inches and higher, we know that that's also a risk factor. And then the male gender, as he mentioned. So when we get three or more of the stop bang, it's a pretty high indication to us that this is probably something we need to test for at this point. And so in terms of testing, once we've decided that we are going to move forward with this, there's two main types of tests. The main one you might have heard about is the in-lab attended overnight polysomnogram, or PSG. And then there's also another test that you do from home called the Modified Portable Home Sleep Test, or HST. So the PSG, the polysomnogram, that's considered the gold standard. This is an overnight study where you actually spend the night in the lab. And the nice thing about the in-lab study, we can get some more accurate sensors and parameters measured while you're in there. So we can look at things like your position. Are you sleeping on your back? Are you sleeping on your side, your stomach? We can also tell when patients are awake or asleep. With the home study, we don't really have the ability to do that. So we just have to assume you're asleep the whole time. The in-lab study is really the one we want to use if someone has some significant comorbid heart problems. So if we're looking for like irregular heart rhythms, the in-lab study has one EKG lead that we can monitor your heart rate and rhythm. Also, if you have like pulmonary issues, so problems with emphysema, COPD, things where we might consider that we need to use additional oxygen, we have the ability to use that in the lab when you're being monitored. And then the other thing with doing the in-lab study is that if we're seeing really bad sleep apnea within the first half, we have the ability to go ahead and start treatment during the second half with CPAP itself just to see how patients respond. One thing I wanted to point out, though, a lot of patients come into the clinic and they're worried that is someone sitting there watching me while I'm sleeping. So there is a technician on site, but they're not sitting in the room just actually watching you. If you look like in the picture on the right-hand side, the middle one, there's videos recording every sleep study. And that's for us as the sleep physician, so we can interpret and review the study. We can make sure there's no abnormal activity happening during the sleep study, no sleepwalking, acting out dreams, stuff like that. But there's not someone just kind of sitting there watching you the whole time. It's just to make sure the signals are showing up well and if we need to go back and review the study. And so this is a schematic of what we're measuring in the in-lab polysomnogram. So you can see there's a couple belts, one over the chest, one over the stomach. Those are to measure how much effort you're putting into breathing at night. If you see the cap on the patient's finger, that's the pulse ox. That measures your oxygenation throughout the night. So if you're stopping breathing, we would expect to see dips in the oxygen throughout the night. And then you see a sensor near the nose and near the mouth as well. That's actually to measure your airflow from the nose and mouth, because if you're having stoppages of breathing, we would expect to see decreases in that airflow too. And then there's a couple of sensors on the scalp, also near the chin and eyes. The scalp is looking at your actual brain waves. So that tells us, are you in light sleep? Are you in deep sleep? Are you awake with your eyes closed? And we can also measure muscle activity in the face, because that will give us indications of what type of sleep you're in as well. And so that contrasts with the home sleep study. And so at Summa, the home sleep study, as you can kind of see on the right-hand side, is you actually come in, you're instructed by a technician on how to put on all the equipment, and then you take it home, wear it for one night in your own bed, and bring it back the next day. The home sleep study is not indicated for pediatric patients, so we only do this for patients between typically 18 to 65. We've made exceptions if we need to go higher than that. Since it's not as accurate as the in-lab sleep study, we like to do this for patients we have a really high suspicion of sleep apnea, and we just need to confirm it. So someone who scored really high on that stop bang scale, they come in with kind of all the physical characteristics that we might consider at a higher risk for sleep apnea, all the symptoms that we're worried about, and we just really need to kind of confirm this diagnosis. That's a perfect candidate to do the home sleep study. But it can miss milder cases, so that's why we want to have those patients go into the lab. As Dr. Gerritsen mentioned before, there's a different type of sleep apnea called central sleep apnea, where the brain isn't sending the signal properly to ventilate, to the lungs to ventilate. And sometimes that's not caught as well on the home study as it would be on the in-lab study. But this is a good study for patients who are immobile. We've had, for example, patients in nursing homes that can't get out to the sleep lab, and we can at least just do it from their own environment. But in the end, honestly, a lot of times it does come down to insurance. So there are patients we want to start with in-lab studies, but if insurance doesn't authorize it, we have to kind of go through by starting with a home sleep study, and then we can kind of go from there. And if it's inconclusive, move on to an in-lab study.
So I think this is one of the more fascinating things about obstructive sleep apnea when I was studying and learning about it, is that, the obvious things that are some of the consequences from sleep apnea that we all think of. So with repeated awakenings, you wake up feeling more fatigued, your concentration's off, your quality of life suffers. All those things I kind of think were obvious whenever you're woken up repeatedly throughout the night. Some of the other things that have been interesting in studies that they've looked at as far as the consequences, depression's a big one. Dr. Deoras mentioned it. There's irritability. There's different changes to your mental status and your mental health associated with sleep apnea. Your memory suffers. Absenteeism increases. So not just the fact of not being able to go to work, but even when you're there, being absent-minded or not present, not able to perform your best. There's also been in studies a questionable link to an increase in cancer risk associated with sleep apnea. And so what happens through this entire sequence of having obstructive events where your airflow is decreased and the oxygen is decreased, and these repeated events over and over throughout the night, is that our fight or flight system of our nervous system kicks into effect. So you get increased secretion of norepinephrine and some of the hormones that are associated with the fight or flight mechanism, because you're in a restful state and then you're woken up, or you can't breathe, and there's a panic that's associated with the body. And so it secretes certain stress-related hormones, and you get things like increased inflammation within the body and increased dysfunction of the lining of the blood vessels. Also, we see different metabolic changes. So there's a decrease in insulin sensitivity, increase in these problems with metabolizing our fats and handling glucose and some of these metabolic markers in our body. The subsequent downside, the effects from this that we ultimately see in patients is high blood pressure, like Dr. Deoras said. Patients can suffer from pulmonary hypertension. I've seen healthy patients with repeated sleep apnea events suffer from arrhythmias, so atrial fibrillation is common. You can see different changes to the heart, so not just coronary artery disease, but CHF or congestive heart failure. Diabetes is a big one. Stroke is another big risk. So you see these things that I think that are more impactful outside of just the increased rate of motor vehicle accidents and difficulty concentrating, but some really serious side effects as far as cardiovascular and mental health that are associated with this as well.
Yeah, so that's why it's so important to treat sleep apnea. We know it can have all these consequences. So we're going to be covering kind of the conservative measures all the way through the surgical treatment options. And the nice thing here at Summa is we have such a wonderful collaboration between sleep medicine and our colleagues in ear, nose, throat. So it's just a great kind of comprehensive and collaborative effort. But in terms of conservative measures, the first thing we always discuss with patients, if it applies, is weight reduction. There have been numerous studies showing that as we lose weight, improves sleep apnea. As we gain weight, it makes it worse. So especially if patients are pretty mild, there's sometimes it can be like mild borderline cases that we can resolve with weight loss alone. Then we also look at positional therapy. So we know that sleep apnea for the majority of patients is worse when patients sleep on their back. When they're on their back, their tongue's falling back, blocking the airway further. So a lot of patients, we can get improvement in their symptoms when they're sleeping on their side. So you can see they sell various devices. The one in the picture is called a Remedy. It's basically almost like a knapsack with plastic canisters built into the back, just to try to make it uncomfortable when you flip over onto your back. They kind of have variable effectiveness. Some people will sleep right through that discomfort. And some patients will kind of make their own devices. They'll sew in tennis balls to the backs of shirts, try to use something just to make it more uncomfortable to sleep on your back. And then we know alcohol makes sleep apnea worse. It relaxes the muscles in the throat that are keeping it open. So we'll see additional collapse of the airway that way. Usually if you know someone or you snore, a lot of times you'll have heard that the snoring is worse after drinking, and that's kind of a pretty common phenomenon. And then we also want to correct any nasal obstruction or congestion so that we're not kind of exacerbating things on top of the airway closure further down. And then for patients with mild cases, we will look at things like a mandibular advancement device. So on the right-hand side, the lower picture, these are also known as oral appliances for sleep apnea. And you can see that it's basically a device you put in your mouth at night. It's pushing the lower jaw forward, typically a couple millimeters, to open the airway. You can see behind the device, the throat opens up, it allows the air to flow in. So this is a really good option for pretty mild cases. Once it gets beyond that, we don't see as much success with it, but it gives us an alternative to use. However, the primary treatment that we're looking at is positive airway pressure therapy, or PAP And that's one that we typically discuss with our patients. And so I'm going to go into that a little bit further, and then afterwards, Dr. Gerritsen will touch on the surgical procedures with you. So CPAP just stands for continuous positive airway pressure. And so you can see on the right-hand side, when someone's laying down, there's the airway is closing up at night. Basically, when the CPAP is applied, the sleep apnea is resolved by basically pushing in positive air pressure to open up it's a mechanical intervention to stent the throat open. A couple of things to keep in mind. This is just using room air. So a lot of patients are under the impression that they're going to get an oxygen tank, or it's kind of some sort of concentrated oxygen, but it's typically room air unless there's some sort of pulmonary issue going on where you need additional oxygen with it. And then the air is heated, it's humidified, it's pressurized, it's sent through a tube connected to a mask. And like I said, it's basically a mechanical intervention. And so the CPAP is considered the gold standard of treatment for all cases, but definitely once it progresses beyond mild, if it's a moderate or severe case of sleep apnea, then we really want to consider CPAP as an option. As Dr. Gerritsen had mentioned, we know the long-term consequences of untreated sleep apnea. So there's been numerous studies looking at CPAP helping reduce blood pressure, reducing the risk of cardiovascular death, stroke, irregular heart rhythms. As he mentioned, atrial fibrillation is a big one that they see tied to untreated sleep apnea. But we also see it can improve insulin sensitivity, so we'll see better blood sugar control. And that's often a typical referral for us as endocrinologists when they're having difficulty controlling patients' blood sugars or hemoglobin A1C. We'll say, let's make sure there's no untreated sleep apnea in the picture. We'll also see improvements in cholesterol and depression. But definitely one of the obstacles to using the CPAP is just adherence or compliance, which is just basically getting patients into the habit of using this every night. It's a different way of sleeping. Some patients have difficulties adjusting with the mask. So that's something we always have to keep in mind. And on the next slide, I've got a couple of just kind of the different masks that are used for this. So you'll see some cover the nose, some cover the nose and mouth. None of them have really been found to be specifically better than the others. It really comes down to patient comfort and tolerability. So we've got options, but it's when patients really can't tolerate this well that I'm then kind of having them consult with my colleagues in ENT like Dr. Gerritsen.
So I'll discuss some of the surgical treatment options that we look at. But before, like Dr. Deoras said, we work closely together to try to avoid all the complications and some of the sequelae that come from sleep apnea. So I love doing surgery. I love making patients feel better. There's nothing that brings me more joy. But I have to admit, the number one therapy for sleep apnea is CPAP. And it is a total cure for sleep apnea patients. And the issue is compliance. I mean, it's a difficult device for some patients to use. I find that the patients who feel like they've gotten significant benefit from it tend to stick with it. So it's not for everybody, but it is a cure for sleep apnea. And for the patients who they cannot tolerate CPAP or they find difficulty with either their bed partner putting up with it, and they've thrown the CPAP device to the side, then we've got to do something to treat it. And so we have a couple options. And this one of the options that comes up from time to time, or has been used for a couple decades now, is the UPPP, or uvulo-palatal pharyngoplasty. And essentially what that is if there's oropharyngeal crowding, or you look in the back of your mouth and there's big tonsils and everything in the mouth is crowded, that could be the potential source of obstruction and obstructive sleep apnea events. And so what we can do is sort of a tonsillectomy on steroids. We can take the tonsils out and then sort of take where the tonsils were and sort of widen the oropharyngeal area to help increase that overall area to allow increased airflow and decrease the obstructive events. Long term, this can be variable. So the anatomy continues to change. As we age, things start to get lax, or maybe the previous suture or the previous surgery, that site starts to change, and you can see some of those results start to fade over time. And it's also a very selective type of surgery, so you need the right candidate. So patients who can open their mouth pretty wide and most of their obstruction is from their tonsils, they'll have a high success rate versus someone where you look in their mouth and you can see a huge, huge tongue and you can barely see the tonsils or the soft palate or the uvula. Those patients are not going to do as well. So really, for this surgery in itself, you have to be very selective in finding the right patients for it. One of the newer therapies is called Inspire therapy, or the hypoglossal nerve stimulator. You may have seen commercials for this. It's been routinely broadcasted and not really explained too well, but they do have quite a bit of advertisements out, and it's gaining a lot of popularity. So what this is, it was FDA approved in 2014, and basically what it is it's a nerve stimulator that hooks onto the nerve that controls your tongue movement, and it's connected to a pacer that sits in your chest just above the second rib, which is connected to another stimulator that sits right near the chest wall. And so what happens is essentially the picture on the right shows the activation device, and about 30 minutes prior to you going to bed that night, you'll activate the device. It'll kick on 30 minutes later, and then every time that you take a breath, it sends a signal to the nerve that controls your tongue movement, and it will activate that nerve, and the tongue will move forward, and the muscles of the back of the throat will contract. Essentially, that will open up the airway, and it essentially tries to serve the purpose of what CPAP does in opening up the airway every time you take a breath via nerve stimulation. This diagram just kind of illustrates the two main surgical sites. So on the left is a depiction of the tongue and the nerve that we're controlling it. So that's made up of different fibers that move the tongue backwards and also forwards. And so we're trying to direct the cuff, and we put a small little cuff around that nerve that activates it so that it will move forward when you're asleep. The picture on the right just kind of shows you the chest anatomy and where we're placing the second lead and also the pacer that controls the device. In depiction, so this is what happens to a typical patient with sleep apnea on the left, where they're not having any stimulation, there's no CPAP therapy, and you can see there's two different depictions of what it looks like inside of the upper airway via scope, looking at both at the level of their base of tongue and also at the palate level, and you can see how it's blocked off. There's minimal airway, especially in the bottom left. That's sort of the area that you're trying to breathe through at night. With the device activated, you can kind of get an idea of what the device is doing. So it contracts those muscles. You can see on the right side, the bottom left picture on the right side, how the improvement in the overall area to breathe through, and especially at the level of the palate, it helps pull the soft palate forward and helps open up the airway so you can get the same effects of CPAP, or open up the airway so you avoid those obstructive events. The STAR trial was sort of the pinnacle trial that helped get FDA approval for the Inspire device. And so they took a subset of patients with around moderate to borderline severe sleep apnea, implanted the device, and checked the patients at 1 year, 3 years, and 5 years out. And you see that the vast majority were able to maintain a level of blood into the mild sleep apnea range in this cohort of study. You also see a significant improvement in the Epworth Sleepiness Scale, which is another measure that we use to assess kind of quality of life associated with the sleep apnea. With that, we're open to take any questions. I know as far as Inspire, I get a lot of patients who come in with questions about the device. Many patients don't even know that it is a surgery. So I think I would like to mention that when patients are starting to think about navigating this, um, we kind of direct to Dr. Deoras first. So it kind of goes in line with first, do you have sleep apnea, and and at least trialing that first line therapy of CPAP therapy, because to even get Inspire therapy or considered for Inspire therapy, part of the criteria is that you've tried CPAP and it has failed, or that you've tried it and for some reason it didn't work. And it doesn't have to be something serious. It can be something that your wife sleeps in the other room now. She can't stand the noise of the machine, or maybe it's not comfortable, or you can't find the right fit. But I think starting with your department, the sleep medicine team, trialing those things to get it under control, and then if we can't, then finding a way that we can treat that to avoid the complications of sleep apnea.
Yeah, I think that's a really good point. We can kind of screen and see where do people fall on the spectrum of their qualifications for Inspire. But sometimes patients haven't ever seen a sleep doctor before too, so we can try to do some troubleshooting, some tweaking of their machines, their masks, to see is there anything we can first do to make it more comfortable before we just kind of give up and go straight to surgery.
Right. So I think I saw a couple questions trickle in. Oh, oh, okay.
Okay.
Gotcha. Okay. I will mention, so the Inspire therapy, I know a lot of patients are excited about this. There are certain criteria which I didn't include in my notes. They can be a little bit strict, but we're typically talking about patients with a BMI of 35 or lower. So that's one of the big criteria that insurance companies will have a hard time being flexible with that. I do have a couple patients who have shown good weight loss, and then they're more considered as far as from the insurance criteria that they're trending in the right direction. But that's a big one. So kind of having an idea of what your BMI is, if it's 35 or lower. I know some of the Inspire folks are optimistic that with some of the newer studies, it'll get up to 40. That remains to be seen, but I mean, if that changes, we'll reach out to people or our patients that we've seen in sleep medicine and open that up. Another requirement is like having a sleep study within 2 years. So some patients will fail CPAP, kind of forget about it or toss their sleep apnea aside for a couple years, and then need to get plugged in, or maybe they saw the Inspire commercial and they're interested. So again, I think that goes back to working with our sleep medicine department and getting that coordinated and getting things up to speed.
Yeah, we can at least make sure that there's something. We need something recent. A lot of patients will come in and say they were diagnosed 10 years ago. We don't know if that really is reflecting where they're at right now.
Right.
And then the other thing we can tell from the study is there are kind of severity requirements too. Dr. Gerritsen mentioned, the initial studies where they were looking at the AHI. That's basically a measure of the number of respiratory events an hour. And so patients to be considered for Inspire kind of have to fall in this moderate to severe range. So they can't be too mild or too severe. And so we get that AHI measure from the sleep study that ensures that they can qualify for Inspire.
The first question that we have is this hereditary?
So sleep apnea, yeah, we do see a higher predisposition to it if it runs in first degree relatives. So it's not a given that you're going to have it, but definitely there's a higher chance if when we have a patient come in and tell me, oh yeah, my mom, my aunts, my grandmother all had this, that we can kind of see a familial predisposition for it for sure.
This next question says, does sleep apnea ever just stop and go away and you don't need the CPAP any longer?
Yeah, so that's a really good question. It comes up a lot in the clinic. The patients say, am I going to just be able to stop using it? And I talk with them about how the CPAP's, just a treatment. Unfortunately, it's not a cure. So once you take away that mass, that pressure from keeping the airway open, it's going to go back to closing up. Like we had talked about, sometimes losing weight can really help. And so if patients have really mild cases, sometimes that can really help resolve it. Or the other case is, even if they have severe cases, we've seen patients when they lose a dramatic amount of weight, sometimes, for example, from bariatric surgery, that we'll see that that may resolve sleep apnea too. But on its own, it actually will do the opposite. It'll tend to get worse over time because, as Dr. Gerritsen mentioned, aging itself is a risk factor for sleep apnea and especially worsening sleep apnea.
What problems have been reported with the Inspire therapy?
Um, so d- w- as far as like aftercare, I mean, I can speak to as far as the surgery. So expectations from the surgery, there's the normal risk of post-operative things. So infection, bleeding from the surgical site, the incision here or near the chest. Biggest one is that we have to place a cuff around the nerve that controls your tongue. So I've seen a few patients who have had a little bit of weakness in their tongue, and it's temporary. So there's been no reported cases where you've actually lost function of that nerve. But it can last up to 2 to 3 weeks, and it can be significant enough that it affects your speech or swallow. Um, there's been reported instances of you're near the chest wall, so you can potentially damage any surrounding structure of the chest. All those are super rare. Um, but after as far as complication from the Inspire therapy, I do think it's worth mentioning that it's a electronic device, and it has a battery life of 12 years. So if you're a younger patient, say in your 50s, and you're having this implant, it's more than reasonable that you may need to undergo a simpler surgery to have that battery pack removed and a new pacer placed in at the 12-year mark. So that's something to think about for younger patients. Outside of that, I don't know, with the Inspires that we've done, have you seen any issues post-programming or?
No, not really. It's definitely an adjustment. So after Dr. Gerritsen does the implantation, or his colleague Dr. Wong, we are seeing patients back about a month later to activate the device. So it's not turned on right during surgery. So we activated a month later, and so far we haven't been seeing any major issues. It's, definitely patients have said it's kind of a different feeling to get adjusted to. So the first week can just kind of feel weird. They're learning how to kind of navigate the device, how their tongue feels when they've got it on, kind of feeling it move forward. But we haven't been seeing any major complications or issues with it.
So this question also directly goes with the Inspire. This person says, my sister has the Inspire and she says that she can feel the shock. Is it true that people can feel it working?
Yeah, I mean, when we activate, they can definitely, so when patients Inspire, first off, is meant to be used when you're sleeping. So it's not something that you're supposed to have on during the day, but if you do have it on while you're awake, you definitely will feel it. Um, some patients might describe it as a shock. A lot of patients just say they can kind of feel their tongue twitching forward a little bit. That's what we're seeing during the activation, is just the tongue kind of moving forward above the lower teeth. So the patients definitely can feel it, but the point is it's supposed to be while they're sleeping. And as Dr. Gerritsen mentioned, there's kind of a delay period, so we can set how long it waits to kick in, so that ideally we're kind of anticipating how long it's going to take you to fall asleep, and it's not really turning on until that period.
And I think it's worth mentioning that, this is titratable. So um, the goal is to provide the least amount of stimulation to help cure or treat your sleep apnea. So afterwards, you're working with Dr. Deoras and working on the sleep study to titrate it to the level that provides the least amount of stimulation while effectively treating your sleep apnea. So the goal is to not stimulate the tongue as much. With that said, though, the nice thing about this is that theoretically, as we mentioned, those things that change in our anatomy, like we get older and things we lose our elasticity or whatever changes we might have, we can adjust the device on the fly depending on what's changed and hopefully effectively treat it and try to titrate it to accommodate for those changes. So.
Yeah, that's a good point.
Okay, this question says, should you have sleep study tests done? every 2 or 5 years?
So yeah, that's a really common question that comes up in the clinic. So I'm glad it was actually asked. When patients come in and they say it's just been a long time since I have it, length of time isn't really an indication that it just needs to be repeated. So we'll look at, are you having new symptoms? Does it feel like, for example, if they're on CPAP, is it not working as well for you? Then we would say, yeah, a new sleep study is indicated. The other thing that we would look at is weight. So if your weight has changed a lot since you were first diagnosed or since they first put you on a CPAP, then we probably may need to do another sleep study just because that can influence what pressure your machine needs to be set at. As Dr. Gerritsen mentioned, for Inspire itself, yes, we do a sleep study because of insurance requirements. There has to be one in the last 2 years. So if we are evaluating patients specifically for Inspire, then we will do a sleep study if it's been longer than that.
This next question says, where can I purchase a CPAP machine and how expensive are they normally?
So ideally, you'd be working with your insurance to help you get a CPAP machine. You can purchase them out of pocket. However, they would still require a doctor's prescription. So if you wanted to just like go, for example, they sell them even on Amazon or CPAP.com. They can run anywhere from $1,500 to $2,500 out of pocket. But they will still make you show a doctor's prescription and kind of designating what pressure the machine should be set at. Most of the time, though, that's not the route patients go. They're using their insurance. Their insurance contracts with a company called a DME, which stands for Durable Medical Equipment Company. And so the insurance will usually take care of sometimes all of the cost of it, or they'll kind of do a rent-to-own program. The benefit of doing that too is, as you're using a CPAP, you need to replace parts. You need to replace the tubing, the mask. So when you're hooked up with your insurance to do that, they've got kind of intervals throughout the year that they'll supply that to you. When you're just purchasing out of pocket from a website, then you're kind of responsible for all those replacement parts too.
Okay. This next question says, can you speak further about the non-surgical options like the dental device? What is the success rate for that?
Yeah, so the dental device, like I said, we try to use primarily for milder cases, mainly because as you start pushing that lower jaw forward, if there's a lot of closures per hour, it really starts to hurt when you're trying to push it too far forward, and it can also exacerbate like TMJ issues. So for milder cases, we have really good success. The success in the studies is kind of all over the place. They're pretty wide ranges. But just personally, I've seen pretty good results in the mild range. Sometimes the insurance coverage can be a little bit less on the dental device than the CPAP. So that's a reason that even in the mild range, we'll still oftentimes look at CPAP first. But we've had pretty good success once it's in the mild range. Moderate and severe, not as much. We'll see that it may reduce the severity, but it's not going to treat it as well as a CPAP once we start getting into those ranges.
This question says, will this presentation be sent to us so that we have this information to refer back to? And I can answer that one, and the answer is yes.
Okay, perfect.
Can the dental device and CPAP be used at the same time?
They can. It becomes pretty cumbersome. So it's not a real popular strategy because you're now putting on a mask and putting something in your mouth. There have been patients that have done that, and yeah, it's really kind of treating it from all angles that way. So it's possible, just not popular.
Yeah, I've even had some patients who have had the Inspire implant and then still use CPAP. So in some of the more severe cases, they can kind of combine therapy. So even if you have Inspire, doesn't mean you couldn't do CPAP, but usually what brought you to Inspire was a failure of CPAP. So, but I have seen cases where they've done both and had good efficacy.
This question says, can you address the Philips recall and the use of the SoClean machine? Do you recommend that your patients not use the SoClean?
Yeah, so the Philips recall kind of threw everything in flux. Basically, they were finding that there was potential from some of the insulating foam to insulate the sound that it can deteriorate over time. And so there was concern about particles that could be then kind of get into the airstream, actually blow into the mask, into the airway, lungs, and what would be the long-term effects of that. Kind of the studies that have been coming out since they've been doing the analyses when Philips initiated the recall are showing there's really hasn't been major issues from this. The biggest have been like coughs, some headaches. But one thing that came up as they were evaluating this was that the SoClean or the ozone cleaners could kind of accelerate the deterioration of that the insulating sound foam in the CPAP. So I have been advising patients if they have Philips models not to use the SoClean just because we know that that might exacerbate that a little bit. But honestly, when they've looked at studies in terms of cleaning the CPAP, it's not that the SoClean does any better than just doing it kind of with your own hand washing. So it's not any big deal to kind of go down. It's less convenient for sure, but to have to clean on your own isn't really a big issue.
That is the last question so far. No new ones have come in.
What about acquiring the CPAP devices and everything? I've had a couple patients come in asking me about Inspire therapy just because either they can't get another replacement machine. Have you been seeing a lot of issues with that or acquiring the device?
Yeah, it's been a really big delay
Yeah.
because once COVID hit, there's two major manufacturers of these machines, Philips and ResMed. And so COVID already caused a shortage with the semiconductor chips. And then when one of the major manufacturers is on recall, there's just been a backlog.
Right.
So that is kind of been an issue where it's taking longer to get a machine now.
Yeah.
Not a question, but a comment. Someone says that Summa Care provided their CPAP pretty quickly.
Excellent.
Yeah,
That's good to know.
definitely.
Yeah.
So should the replacement CPAPs from Philips be better with the use of SoClean, or do you still not recommend that?
I mean, yeah, so far they're saying basically the replacement machines are using a different type of material that's not supposed to be affected by SoClean. The FDA came out and said that they don't recommend SoClean over hand washing for any machine. But we haven't been telling patients exclusively not to use the SoClean with the replacement one since that's not been shown to be an issue.
That was the last question as of now.
So, Dr. Gerritsen, what are you doing for patients? Sometimes we get patients who come through for a sleep apnea test and they're not actually found to have sleep apnea and just found to snore. Are there any surgical options for them?
Yeah. So when they don't meet the criteria for sleep apnea, we do have those patients come in and kind of do a full airway assessment to try to find the area that's suspicious for snoring. So some patients will come in and make it pretty clear that they can't breathe through their nose or it's problematic at night. And maybe they've started using some of the nasal sprays and it seems like their snoring has improved. Those are patients that we'll discuss potentially correcting the septum or doing a procedure called a septoplasty to straighten out the nose and try to help with nasal airflow. Another indication for that too is if they are okay on CPAP device, but they find their pressures are climbing. So they notice that just airflow is not moving well through the nose. And that's actually a great point that one of the things that septoplasty has been proven to shown is it doesn't cure sleep apnea. It may lower your severity or the AHI index by 6 or 7, but it does help with CPAP compliance, getting the pressures down, make it more tolerable. So I typically take those patients, do a full head and neck exam, see if there's any nasal obstruction. Is there anything in the oropharynx like a more lax soft palate or floppy soft palate? And then kind of cover the options as far as that we can offer to help treat the snoring. The septoplasty and treating the nose is much more amenable to insurance coverage than some of the other things. So there's different treatments for the soft palate to strengthen it so that it doesn't vibrate and cause that snoring. But insurance can be problematic as far as some of those procedures. So some patients are paying out of pocket to take care of that.
This question says, if the base of the tongue is weak, would the Inspire device be more beneficial than the CPAP?
I would say no. Like I said previously, that CPAP does a great job as far as taking care of any tongue-based weakness or any obstruction with what they call a pneumatic splint, or basically a mechanical airway opening of your airway. And it's titratable enough that it can address certain kinds of different obstructions, whether it's tongue-based weakness or at the soft palate, but it's effective. And so I wouldn't say anatomy-wise that there's a patient that I look at and assess and say, oh, this area of weakness is a problem. Inspire would be more indicative for this patient, or be more helpful. I think it's more, how is CPAP going and where are you at treating your sleep apnea? If we're not getting anywhere with CPAP, then I think that makes you more of a candidate for Inspire than anything else.
Yeah.
So there are no more questions at this time, but a couple of thank yous for the informative presentation.
Well, we appreciate everyone who was able to make it, and it's definitely an exciting time for myself, especially with Dr. Deoras. I mean, my goal was definitely to come back to Summa. This area, the Canton-Akron area, is kind of didn't have a lot of solutions for some of the patients who are left out in the cold with CPAP, and just didn't like it. And I think that our bariatrics program here has done an excellent job of creating a collaborative effort where patients can come in and sort of one-stop shop and get that problem treated. So I think Dr. Deoras and his staff have been doing an excellent job, and I think we're getting there. I think that patients are coming in, and we're starting to get the things in place to effectively treat sleep apnea, whatever method it may be, whether it's surgical or we're treating it with CPAP therapy. So it's exciting.
Yeah, definitely. I want to thank everyone too, and like Dr. Gerritsen said, it definitely is an exciting time to be able to offer new options in conjunction with our colleagues. We've got kind of a multidisciplinary growing sleep department, and I'm glad to see it too. I'm originally from the Akron area, so to be able to see this being offered here locally, to just give patients as many options as possible, it's a really great time.
Yeah, and I don't think there's any question. I would say, when we talked about those complications, if there's any concern that potentially you or someone you know is suffering from it, I think it's worthwhile to come in, and we're happy to see you, happy to talk about it, and happy to evaluate. And it's something that you may feel like it's just you're feeling tired and a little bit sluggish during the day, but those consequences, I think it's worthwhile to not neglect those. That this is something that we're finding more and more information about the detrimental impact of untreated sleep apnea. It's something we can help with.
Yeah. So if you're experiencing any issues, definitely it's worth coming in, getting checked out. We get a lot of patients that are kind of pushed into it by their bed partners, and that's fine too. At least it's a way to get this addressed. But just so you know that there's some options, that there is the hope and possibility of feeling hopefully much better the next day, and for improving your long-term health too. We've got the number here for you to call to if you want to be scheduled for an appointment with one of the sleep specialists here at Summa. You can also go on the website, read more about the department, our providers. So please go ahead and do that. And it was asked before, this presentation is going to be available for anyone to view as we go along. So you'll have this as a resource, or to tell your friends and family about, so that hopefully they can learn more about this and get checked out if they might be having sleep issues.